This video is for educational and informational purposes only and should not be considered professional coding, medical, or legal advice. Welcome to Module 4. We're building nicely through this course. You now have a solid foundation in ICD-10-CM and CPT. Today, we're adding the third piece of the coding puzzle, HCPCS Level II. HCPCS, pronounced HCPCS, stands for Healthcare Common Procedure Coding System. While CPT codes were developed by the American Medical Association primarily for physician services, HCPCS Level II was developed by CMS, the Centers for Medicare and Medicaid Services, to fill the gaps that CPT doesn't cover. Think of it this way. CPT tells you what the doctor did. HCPCS Level II covers everything else: the wheelchair the patient went home in, the insulin the nurse injected, the ambulance that brought them to the hospital, the prosthetic limb fitted after surgery. These codes are essential in any setting that bills Medicare or Medicaid, and that's the majority of healthcare in the United States. If you're going to be a complete, versatile coder or biller, HCPCS Level II is not optional knowledge. Let's get into it. Here's what we're covering today. 6 focused topics. Topic 1. The HCPCS Level II Overview. We'll establish what this code set is, who manages it, and critically, how it fits alongside CPT in the real world of billing. Topic 2. Code structure. HCPCS Level II codes are alphanumeric, starting with a letter, A through V. Each letter section covers a specific category of items or services, and knowing the layout helps you navigate quickly. Topic 3. Durable Medical Equipment, or DME. This is one of the most commonly tested HCPCS areas on the CPC exam. DME covers items like wheelchairs, walkers, hospital beds, CPAP machines, and orthotics. There are specific coverage criteria for Medicare DME that you absolutely need to know. Topic 4. Drug and injection codes, which are called J codes. These cover injectable medications, infusions, and chemotherapy drugs. J codes have very specific dosage requirements that must be matched to the clinical documentation. Topic 5. Ambulance and transport codes. Emergency and non-emergency medical transport has its own coding system within HCPCS, and there are specific modifiers for things like mileage and transport origin. Topic 6. HCPCS modifiers. These are different from CPT modifiers. They include things like laterality modifiers, left side versus right side, supervision modifiers, and others that only exist within HCPCS Level II. Let's start with the big picture. Let's get our bearings first with a side-by-side comparison of CPT and HCPCS Level II, because understanding the relationship between these two systems is foundational. You may hear HCPCS referred to as a two-level system. Level 1, HCPCS, is actually CPT, those 5-digit numeric codes we covered in Module 3. Level 2, HCPCS, is the separate set of codes we're focusing on today, the letter plus 4-digit alphanumeric codes maintained by CMS. CPT was developed by the AMA and covers physician services, surgical procedures, most diagnostic tests, and outpatient clinical services. It's updated once a year. On January 1st, HCPCS Level II was developed and is maintained by CMS, the Centers for Medicare and Medicaid Services, and it covers the items and services that fall outside CPT's scope: DME, injectable drugs, ambulance services, prosthetics, orthotics, and more. Unlike CPT, HCPCS Level II is updated quarterly in January, April, July, and October. This matters because drug codes in particular change frequently as new medications get FDA approval and new J codes are assigned. The code format is one letter followed by 4 digits, so while a CPT code for a knee replacement might be 27447, an HCPCS code for a knee orthosis would look like L1940. When do you use HCPCS Level II instead of CPT? The general rule: if there's a CPT code that describes the service, use CPT. If there isn't, especially for supplies, DME, and drugs, you turn to HCPCS Level II. And if you're billing Medicare or Medicaid, HCPCS Level II isn't optional. CMS requires it. Let's map out the entire HCPCS Level II code set by section. This is your roadmap. Knowing what each letter section covers means you'll always know where to look when you need a code. HCPCS Level II runs from the letter A through V, skipping a few letters like F, I, N, O, U, and W through Z. Let me walk you through the most important ones. A codes: ambulance and transport services, plus medical supplies like surgical dressings and sterile supplies. When you need to bill for an ambulance trip, you're in the A codes. E codes: durable medical equipment. This is a heavy section. Wheelchairs, walkers, hospital beds, CPAP and BiPAP equipment, nebulizers, suction equipment. If it's equipment the patient uses at home for a medical purpose, it's probably an E code. J codes. This is one of the most frequently used sections in HCPCS. J codes cover injectable drugs, everything from a simple B12 injection to chemotherapy infusions to biologics. The challenge with J codes is that they're coded by dose, and you need to match the documented dose precisely to the code's unit description. L codes: prosthetics and orthotics, lower limb prostheses, knee braces, spinal orthotics, diabetic shoes, all in this section. G codes: professional services and procedures for which there's no equivalent CPT code. Medicare uses G codes extensively for things like diabetes prevention programs and certain preventive services. K codes: temporary codes used while CMS evaluates whether to establish permanent coverage for a DME item. These are commonly used for Medicare DME billing. T codes: Medicaid services, home health, behavioral health, residential treatment. These are primarily used by state Medicaid programs. You don't need to memorize every code in every section, but you absolutely need to know which letter takes you to which category. That skill alone will save you tremendous time when coding or taking your exam. Durable medical equipment, or DME, is one of the most commonly tested HCPCS areas on the CPC exam, and it's also one of the highest fraud areas in Medicare billing. That combination means coders and billers need to know it cold. Before we look at the codes themselves, let's nail down the Medicare definition of DME, because all 4 criteria must be met for Medicare to cover a piece of equipment. 1. It must be able to withstand repeated use. A disposable item is not DME. 2. It must be used primarily and customarily for a medical purpose. Sunglasses are not DME. Prescription eyewear can be. 3. It must not be useful to a person who is healthy. A standard recliner chair is not DME. A lift chair with a prescribed medical purpose may qualify. 4. It must be appropriate for use in the home. Hospital equipment used exclusively by clinical staff would not qualify as patient DME. Now, let's look at some common DME codes by category. Under mobility equipment, E codes cover canes, walkers, rollators, hospital beds, and K codes cover wheelchairs. Notice that standard wheelchairs are KZ01, while a lightweight wheelchair is KG05. CMS distinguishes between types of wheelchairs because coverage criteria and reimbursement rates differ. Under respiratory equipment, CPAP devices are E0601. BiPAP is E0470. Oxygen systems have separate codes depending on whether they're portable or stationary and whether they use liquid or gaseous oxygen. Now here's a critical compliance point for DME billing. Medicare requires a Certificate of Medical Necessity, a CMN, and a physician order for DME. If the documentation doesn't support the medical necessity of the equipment, Medicare will deny the claim. This is a major source of audits and fraud investigations in DME billing. Document everything. J-codes are the section of HCPCS Level II, used to bill for injectable, infusible, implantable, and inhalable drugs. They're used constantly in hospitals, infusion centers, oncology practices, and any clinical setting where medications are administered to patients, rather than dispensed as prescriptions. Here's what makes J-code billing unique. Unlike most codes, J-codes are tied to both the drug and the dose. You need to know what was given and how much was given to assign the correct code and the correct number of units. Let me give you the 3 rules of J-code billing. Rule 1. Code by the documented dose. The physician may have ordered a 200 mg dose, but only administered 150 units. You code what was given according to the clinical documentation, not what was ordered, and certainly not the entire vial size. Rule 2. Match the route of administration. J-codes are specifically for non-oral routes: injections, infusions, implants. If a medication is taken orally, you do not use a J-code. Oral drugs are typically reported using the NDC, the National Drug Code DESIN, number on the claim. Rule 3. Units must match the code's per-unit description. This is where a lot of billers make costly mistakes. If a J-code says per 10 mg and the patient received 30 mg, you bill 3 units of that code, not 1 unit. Getting this wrong means you either underbill and leave revenue on the table, or overbill and create a compliance problem. Look at the examples on screen. J9035 is bevacizumab avastin, a chemotherapy drug billed per 10 milliliters. If a patient receives 400 milligrams, you'd bill 40 units of J9035. J3490 is the unclassified drug code, used when no specific J-code has been established yet for a particular drug. Claims using J3490 typically require a narrative description and often go through manual review by the payer. Let's cover 2 more critical areas: ambulance codes and HCPCS-specific modifiers. Ambulance codes. These are A-codes, and they have their own unique billing logic. When a patient is transported by ambulance, you need at minimum 2 codes, one for the transport level and one for mileage. The transport level depends on what kind of life support was provided. BLS, basic life support, is for patients who don't require advanced interventions. ALS, advanced life support, is for patients requiring advanced interventions like cardiac monitoring, IV therapy, or airway management. ALS Level II, coded as A0433, is for the highest level of ALS service involving 3 or more medications or 1 or more ALS procedures. A0425 is the mileage code, billed per loaded mile, meaning the miles traveled while the patient is actually in the ambulance. For air ambulance, A0431 is for fixed-wing aircraft, and A0436 is for rotary-wing helicopters. Now, HCPCS modifiers. These are completely different from the CPT modifiers we covered in Module 3. LT and RT are the laterality modifiers. When a procedure is performed on one side of the body, left or right, you add LT or RT. This is critical for bilateral procedures billed separately. GA, GY, and GZ are Medicare-specific modifiers related to coverage and advanced beneficiary notices, called ABNs. If a provider suspects Medicare will deny a service but wants to bill the patient, they must have the patient sign an ABN first, and then append GA to the claim. GY means the service is never covered by Medicare. It's statutorily excluded. GZ means you expect denial, and there's no ABN on file, which means you cannot bill the patient. KX is the medical necessity confirmation modifier for DME. It tells Medicare that the coverage criteria have been met, and the documentation is on file. NU, RR, and UE indicate whether a DME item is new, rental, or used equipment respectively. These affect reimbursement rates. 3 practice cases. Let's apply everything we covered today. Case 1. A Medicare patient with COPD gets a brand new stationary oxygen concentrator for home use. The physician has documented the medical necessity, and the supplier is billing for a new unit. First, we need an E-code for the equipment. A stationary oxygen concentrator is E4390. Now, what modifiers do we need? Since this is Medicare DME, we need KX to confirm that the coverage criteria have been met and the documentation is on file. And since the equipment is new, not rented, not used, we add NU. Final answer, E4390 KX NU. If the supplier had rented the equipment instead of selling it, NU would be replaced with RR for rental. Small modifier difference, big reimbursement difference. Case 2. A patient receives 8 milligrams of dexamethasone sodium phosphate by IV infusion in the clinic. We look up dexamethasone, that's J-O-N-N. But we need to check the unit description. J-100 is per 1 use. The patient received 8 mg. So, we bill 8 units of J-100. That's it. No modifiers needed for the drug code itself, though there would be a separate infusion administration code from the CPT section. Case 3. An ALS ambulance responds to an emergency, picks up a patient, and transports them 12 loaded miles to the hospital. We need 2 codes here, always. First, the transport level. ALS emergency transport is A0427. Second, mileage. A0425 is the ground mileage code, billed per loaded mile. 12 miles means 12 units of A0425. Final answer, A0427 plus A0425 times 12 units. 3 cases, 3 HCPCS scenarios. DME with Medicare modifiers, J-code unit calculation, and ambulance base plus mileage coding. All real-world situations and all commonly tested. Great work today! Module 4 done. Let's lock in those key takeaways. 1. HCPCS Level II fills the gaps that CPT leaves. Whenever you need to code for equipment, supplies, drugs, or transport that aren't covered by a CPT code, especially for Medicare and Medicaid, HCPCS Level II is your go-to. 2. The code format is 1 letter plus 4 digits. Each letter section covers a distinct category of items or services. Know your letters: E for DME, J for drugs, A for ambulance, L for prosthetics and orthotics, and you'll always know where to look. 3. DME billing has compliance teeth. You need medical necessity documentation, a physician order, and usually a certificate of medical necessity. Missing any of these is an audit risk. 4. J-codes are dose-dependent. Match the documented amount to the code's per-unit description and bill the appropriate number of units. Overbilling or underbilling drug codes is one of the most common billing errors in clinical settings. 5. Ambulance billing requires 2 codes: the transport level and mileage. Never bill ambulance transport with just 1 code. 6. HCPCS modifiers are a separate universe from CPT modifiers. LT and RT for laterality, GA, GY, GZ for Medicare coverage status, KX for medical necessity confirmation, and NU versus RR for purchase versus rental of DME. For your Module 4 assignment, complete the HCPCS section identification workbook, work through J-code dosage scenarios, and review Medicare DME coverage criteria for the 10 most common items. That last one is going to serve you in both your exam and in real billing work. Module 5 is next, and it's one students always get excited about because we finally put it all together. We're covering medical billing, the CMS 1500 claim form, the UB04 electronic claims, and the explanation of benefits. See you there!